100%. इसका ये तो लग ही गया, इसका लगा हुआ, उसका doesn't matter. Okay, but what is this black line? Acha, this is going to come. This will hide my slide. Let's take it. We can talk. Somewhere in the center. I have this.
Okay.
Arrows coming there.
Okay. Good morning. You're ready, Dr. Menu?
So just a minute, sir.
Yeah.
Is this fine? Yes, sir.
Yeah. Good morning, all the students and all the live members present here. We will today we have Professor Dr. Minu Taneja, who is a senior periodontist from Delhi and executive committee member of Indian Society of Periodontology, to give a lecture on a very, very important topic of classification of periodontal disease, which is of interest for most of the postgraduate students. Over to you, Dr. Minu, for your scientific presentation.
Thank you so much, sir. And so, as we know, my topic for today is classification of periodontal disease. And what comes to your mind when you think about classification of periodontal disease? The first question that comes to my mind actually is, why do we need a classification? And it's because a classification helps us to scientifically study the etiology, pathogenesis of the disease, and also the treatment of a disease in an orderly fashion. It enables in diagnosis, prognosis, treatment planning, and also in predicting the outcomes, and ensures implementation of appropriate treatment. Classification is like an international language for communication among clinicians, researchers, students, and epidemiologists, and even the healthcare workers. And it facilitates an international population surveys of disease prevalence. So let's look at the historical development of the classification system. And when we look at the historically at the classification, it is actually divided into three dominant paradigms. And the first one is from 1870 to 1920. And that is when the classification was primarily based on the clinical characteristics of the disease. Because that time we had little knowledge about the etiology and the pathogenesis of the disease. And so during this time, it was C.G. Davis in the year 1879 that he classified periodontal disease as gingival recession, periodontal destruction due to Lyme, and Rick's disease. During the same time, G.V. Black used the terms like constitutional gingivitis, simple gingivitis, painful form of gingivitis, and calcific inflammation of the peridental membrane. The next prominent domain was from 1920 to 1970, and this was the classical pathology paradigm. And it was during this time that periodontal disease classification was given by Orbans in 1928, where he classified periodontal disease into two categories as simplex and complex. And around the same time, Gottlieb classified periodontal disease into an inflammatory and a non-inflammatory periodontal disease, also called as periodontosis. And it was when Robert Koch gave the germ theory of the disease, the scientific started thinking probably periodontal disease is caused by bacteria. And the first proponent of this was W.G. Miller, who was an early proponent of this concept. And however, it was only after the classical experimental gingivitis studies that was carried out by Lowe that we started to understand the infection and host response. And so many classifications were proposed from 1970 onwards. And these are like the AAP classification, the Ramford and Ash classification, Page and Schroeder. So if we just look at the AAP classification itself, the American Academy of Periodontology classification has evolved from 1977 to 1989, from just being two categories. In 1989, it became 5 categories. And if you look at the 1989 classification, which was actually widely accepted by the clinicians worldwide, the classification, this classification was based on the age of onset of the disease. And so periodontal disease was classified into an early onset periodontitis, prepubertal and juvenile periodontitis, and then we had adult periodontitis, necrotizing ulcerative periodontal disease, refractory periodontitis, and a section on periodontitis associated with systemic disease was added for the first time in the 1989 classification. However, this classification had a lot of shortcomings and implementation issues as it had a lot of overlap, and the criteria were not very clear cut. So after 10 years later, American Academy of Periodontology had a world workshop in which a group of experts, they now scientifically they proposed a classification which was scientifically accepted. And as you can see, it was for the first time in this classification, gingival disease component was added. And now age was not given as a prime importance. In fact, the term adult periodontitis was replaced with chronic periodontitis because the evidence suggested that chronic periodontitis could also be seen in adolescents. And similarly, early onset periodontitis was replaced with aggressive periodontitis, because this classification was based on the rate of progression over a period of time. And periodontitis as a manifestation of systemic diseases component was added. The new thing also in this classification was addition of abscesses of the periodontium and addition on the periodontitis associated with endodontic lesions, developmental and acquired deformities and conditions, and occlusal trauma. So as we look at this whole classification, the 1999 classification was quite elaborate classification, and it had a workable framework, which we had been using extensively. And actually we had been using this classification from the past 2 decades. But the classification itself, if you see, suffered from several important shortcomings, and there were difficulties in applying the stipulated criteria of the classification in a day-to-day clinical practice. For example, the classification had a substantial overlap, and it lacked a clear pathobiological based distinction between the categories, which caused implementation difficulties. At the same time, when assessing, the classification actually depended upon assessing the rate of progression, which was spread over multiple appointments to diagnose aggressive periodontitis. This means that the patient needs to repeat the clinical visit just for him or her to be placed under a certain form of periodontitis, which is not practically possible. Also, if you look at the criteria of the 1999 classification, which is laid down for chronic periodontitis as well as aggressive periodontitis, you'll see that a lot of clinical situations where it would be difficult to assess in which category you can place the patient, because There are times when chronic periodontitis case may also have a rapid breakdown. And the other dimension is that attachment loss in the absence of periodontitis, that is recession which has occurred because of toothbrush trauma, cannot be considered as a periodontitis case. And even though there had been a rapid, vast advancement in the field of implantology, and in fact, I would say implant practice is now becoming almost the mainstream, the 1999 classification had nothing for diseases around implants, and that left a significant void. And another important point here is that there are certain patients you would see that would respond very well to your conventional therapy, while there are patients who would require your extra attention and care. And these patients are the patients who are at risk. And so the classification, 1999 classification, did not consider risk factors into, or it did not take these into considerations. So it was time, and it was a need of an hour to update the classification. And that is why in 2017, the European Federation of Periodontology, as well as American Academy of Periodontology, in 2017, they sat together. So this is the group that actually worked on the classification. And what they felt is that there was a need. They went through all the evidence and related to diagnosis, related to classification, and they decided that there was a need to update the classifications so as to accommodate the knowledge in terms of research that had gathered up since 1999. And so they came up with the 2017 classification, and this classification is essentially based on biological, it's actually a biologically based classification, which looks at precision medicine. And what do I mean by that? The way we treat our patient now is very different. It's more of precision based. It's more of personalized treatment to the patient, and it is tailored to the patient. So it is no more about blood. It's more than that. So we needed a classification which would be biological based classification that embraces the concept of precision medicine. And what do I mean by that? What are the key elements of a biologically based classification system that embraces a precision medicine? Is it involves a microbial dysbiosis within the plaque. Next component is the hyperinflammatory host response, and actually in perio, it's always an exaggerated host response. And the third component of this is the patient, individual patient. Every patient, if we look at, is different. Their environments are different, their genetic is different. So the way a patient responds to plaque is different. So that needs to be incorporated in the classification, and that is the essence of the 2017 classification, that it is looking at a biologically based classification, and it is embracing the concept of precision medicine by incorporating the risk factors into the classification. And also, as we still haven't understood the entire biological process to go up to full biological classification. So what the experts have said that this classification is like a live system that is going to be regularly updated as more and more evidence is collected and is evolved. So what's new in the classification? So let's look at the classification now. And if you can you see my cursor here? So the classification essentially is divided into two main components, that is the periodontal disease and conditions, and the peri-implant disease and conditions. And so I'm very happy about it. This is for the first time, peri-implant disease and conditions have also been addressed in the classification. And if you look at this periodontal disease and conditions, it is further divided into three components: the periodontal health, gingival disease and conditions, periodontitis, and others affecting the periodontium. So what's new, if I compare it to the 1999, is under the periodontal health and gingival diseases, this is for the first time we are going to be talking about health. And health has been given importance. And I truly believe that you cannot understand disease till you understand health. And if I look at this section of periodontitis and compare it to the 1999 classification, so we have only 3 sections here now. It is only necrotizing periodontal disease, periodontitis as a manifestation of systemic disease, and just periodontitis. So there is no more aggressive and there is no more chronic. But it's not that simple. Actually, it is simple, and we'll go through this. It is more, there's more to it, and we'll be discussing it later. And so, and when we look at this section, the other conditions affecting the periodontium, so it is almost the same, where we have systemic diseases affecting the supporting structures. Then you have periodontal abscesses and endoperio lesions. I used to like it when we used to call it perioendo lesions, but now it is no more perioendo, we call it endoperio lesions. And mucogingival deformities and conditions, we have traumatic occlusion and tooth-related factors. So we're going to take and discuss this classification part by part. And the first part that we're going to discuss is about periodontal health, gingival diseases, and conditions. So as you look at it, as I said before, it's for the first time that health was given importance. And why is it important? Because it is critical to establish an ideal and acceptable therapeutic endpoints to periodontal therapy. And that is why a definition of health and defining periodontal health is so much important. So how does World Health Organization define health? So according to World Health Organization, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So when I say that, and I ask you, what do you think would be a case of periodontal health? Does this come to your mind? Some of you might be thinking it could be a pristine gingiva, or some of you might be thinking, oh no, some amount of inflammation or some amount of bleeding is allowed. And let me ask you, when is the last time you had a patient in your practice who had 0% bleeding? Probably never. So if you're thinking about pristine gingiva as a case of clinically healthy gingiva, what's a pristine gingiva like? The one which has absence of inflammation, there is no inflammation at all, and the periodontal ligament, junctional epithelium, and the bone are in perfect anatomy. But does pristine gingiva really exist? Does pristine gingival health exist? Yes, it do, but only in less than 5% of the population, and that's not normality. Normality is one that exists in 90% of the population or more. So what exactly is a clinically healthy gingival case? So let's look at this. Before I explain you that, I want you to understand this concept, this model, which was given by Chappell in 2015. And if you see here that even in clinical health, there is some amount of immune surveillance in the form of inflammatory mediators. And however, these are in symbiosis, and this host response is consistent with homeostasis. And in case of gingivitis, there is an incipient dysbiosis that you see. And in case of periodontitis, this dysbiosis now becomes a frank dysbiosis. So what I mean to say here is, even in case of clinical gingival health, it is always associated with an inflammatory infiltrate, which is actually consistent with homeostasis. So what does clinical health look like? If you look at this case over here, and this patient has absolutely no attachment loss, and there is no bone loss, and the gingiva is pink, it is stippled, it appears healthy. So this is more like a case of you would say, a clinically healthy gingiva. But if you look closely, you find that in the lower anteriors, there is a slight rolled out margin of gingiva, and there's a slight edema. So is this a case of clinical healthy gingiva, or would you call it as a localized gingivitis case, I would say it's a case of clinically healthy gingiva and which has a slight inflammation. So if this is case versus site, you can have a case of a clinically healthy gingiva, but there can be a site of inflammation, and that also is a case of clinical health. So what is the the objective way to define it? How would you know that this is a case of health and not a case of gingivitis? The objective way is to use bleeding on probing as a measure, and what you're going to use is a standardized probe and a probing force of about 25 grams, and the cutoff that is given is 10%. Just I hope you can see my cursor. And so if you have, so in an intact periodontium, a health would be defined when you have no probing attachment loss, you have no bone loss, and the sulcus depth is less than 3 millimeter, and the bleeding on probing is less than 10%, which means that essentially it's a healthy gingival case, and probably one or two sites, which is like less than 10%, may have some pinpoint spots of bleeding, right? And in case of a gingivitis, it is more than 10%. The rest all would be the same. So, and further, you're going to apply the 10% and the 30% rule over here. So if you have sites which are more than 10%, it is a case of gingivitis, localized gingivitis. And when this increases to 30%, more than 30%, it's a case of generalized gingivitis. So what exactly is the spectrum of periodontal health? And health can also be achieved in an intact periodontium, whereas health can also be achieved on a reduced periodontium in a stable periodontitis patient, a patient who had a successful periodontal therapy, or in a non-periodontitis patient. So what do I mean by a reduced periodontium in a non-periodontitis patient? Is that a patient who had undergone a crown lengthening procedure, or a patient, for example, who had undergone a removal of a wisdom tooth, which has caused bone reduction in distal to the 7. So these are the spectrum of clinical periodontal health. So when we move from diagnosis, classification to diagnosis may not always be the same. And it is important to have a classification to form the diagnosis so that we can classify the patient into different categories. So a patient with periodontal health would be the one, as I said before, will have sulcus depth of about 3 millimeters or less, and the bleeding is less than 10%. Okay? So, and there is no bone loss and there is no attachment loss. And that is the case of patient with periodontal health. You will classify it as a patient with periodontal health. And when this patient has accumulation of biofilm, this patient will develop gingivitis. And gingivitis, as we know, is a reversible condition. And in a risk patient, this gingivitis may progress to periodontitis, where there is an attachment loss and bone loss. And as we know, attachment loss and bone loss is an irreversible condition now. And so the arrow moves only in one direction now. Okay. So this is pretty much the classification from health to gingivitis to periodontitis. However, this periodontitis patient, after the treatment, after the successful treatment of periodontal disease, can actually be in a state of health. So when the classification is turned into diagnosis, it's pretty much straightforward in terms of health and also in terms of gingivitis. But in case of periodontitis, one scenario would be one if that you have done a periodontal therapy and it is successful, and now the bleeding and probing is less than 10%. You have pocket depths which are less than 4 millimeter, and there's no bleeding at the 4 millimeter site. Because if there is bleeding at the 4 millimeter side, it becomes a case of periodontitis or active periodontitis. So this is a patient we have been able to achieve health after the periodontal therapy, and so it will be called as a periodontally stable case. The other outcome of your therapy could be that yes, your therapy was successful, but there is still some signs of inflammation present. That is, the bleeding is more than 10%, but however, the pockets are less than 4 millimeter, and there is no bleeding on probing at the 4 millimeter sites. So this patient we will be calling as a remission case, who has a slight inflammation on even after the therapy. And the other outcome, which we don't want actually to happen, is a patient who still after therapy has a pocket depth which are more than 5 millimeter. The probing pocket depth is greater, or the probing pocket depth is greater than 4 millimeter, and those sites have bleeding on probing. And this could be either due to unsuccessful treatment or because of a relapse. So again, I'm repeating, emphasizing on this, that once a patient is a periodontitis patient, it's always a periodontitis patient. Because it's an irreversible condition, this patient will always remain a periodontitis patient, but such patient can be a case of health, as you can see over here. And that is the reason we need to take into account for health in case of a reduced periodontium in a periodontitis patient, because this patient would require an ongoing risk assessment. It's the same as saying that a patient with diabetes is always a diabetic case. However, the patient may be saying that, I have been able to control my sugar levels, and but this patient would always require an ongoing checkup of his status of his diabetes. So it is almost the same as that. So how can we define health? Let's just summarize it in an intact periodontium is when you have no attachment loss, no radiological bone loss, and the pocket depths are less than 3 millimeter, and the cutoff, as I said, which is very important, as the bleeding and probing is 10%, less than 10%. And how do you define gingivitis on an intact periodontium is that you have everything else is the same, but the bleeding is now more than 10%. How do you define health in a reduced periodontium in a non-periodontitis case? Is yes, there could be attachment loss, the possibility of a bone loss, especially if, for example, like after extraction of a third molar. However, the bleeding on probing is less than 10%, and in gingivitis, yes, there is a bleeding on probing present. And you could also define health after successful treatment of a periodontitis case. And yes, there would be attachment loss, there would be bone loss. The probing pocket depths, however, would be less than 4 millimeter, and there should be no site with 4 millimeter, where there is 4 millimeter with bleeding on probing. And the overall bleeding on probing should be less than 10%. So, but you do not call this patient as a healthy gingival case. What you say is that this patient has stability. So you call it as a stable periodontitis patient. And similarly, a patient who had a periodontal therapy done but had some amount of gingival inflammation would not be called as a gingivitis case, because you cannot have two diagnoses in the same patient. And as I said earlier, a periodontitis patient is a periodontitis patient for life. Now, this patient has a probing attachment loss, has radiographical bone loss, and there are probing depths which is less than 3 millimeter, but this is going to be a case which has gingival inflammation, and it's a case of remission. So the key points to remember here is gingival health is defined as less than 10% sites of bleeding and probing, and the probing depth has to be less than 3 millimeter. Clinical health can be restored following treatment of gingivitis and periodontitis. And a case of clinical health is different from a site of clinical health. And in a periodontitis patient, the term gingival inflammation is used rather than gingivitis. So the next part is about gingival diseases which are non-biofilm induced. So non-dental plaque biofilm induced gingival diseases, these include a variety of conditions that are not caused by plaque, and usually they do not restore following plaque removal. And such lesions may be because of a manifestations of a systemic conditions, and they could be localized just to the oral cavity. So a clue here is that how can you distinguish them from a plaque or biofilm induced case is that if the inflammation extends beyond the mucogingival junction, and this is usually very unlikely to happen in case of a biofilm-induced gingival inflammation, then it is a case of non-biofilm-induced gingival diseases. And the spectrum of diseases over here it includes genetic and developmental disorders like hereditary fibromatosis, specific infections which include bacterial origin, viral and fungal origin, inflammatory conditions like hypersensitivity reactions or granulomatous inflammatory conditions, reactive processes like pyogenic granulomas, neoplasms, and endocrine and nutritional metabolic diseases. It is important here that we need to distinguish these diseases from systemic diseases that can affect the deeper periodontal tissues. And it also includes traumatic lesions as well as gingival pigmentations caused by drugs, amalgam tattoo, etc. So that pretty much brings us to the end of part 1, which included health and gingival conditions, diseases of the gingiva. So now let's discuss the part 2, which is very important. And as you can see here, but it has only 3 components, and that is no more aggressive and no more chronic. So we have kind of said goodbye to them. And why did we do so is there was no evidence of a specific pathophysiology that enables the differentiation of cases as aggressive or chronic periodontitis, or provide guidance for different kinds of interventions. And also what the second group of the workshop, when they look at the evidence, they realize that there was little evidence from the biological studies that aggressive and chronic periodontitis are like a different disease entities. With the exception of only localized aggressive periodontitis, where a clearly defined clinical phenotype does exist, but there was a kind of unease about including this as a separate entity. And the other evidence that they looked at, the second workshop group looked at, was that there is an evidence that there are multiple factors, and the interactions of these factors can influence a clinically observable disease outcomes at the individual level. That means there are risk factors that can affect a disease phenotype of an individual. And also when they looked at the population studies, so they looked at 2 population studies, the NAN studies in US and the one in Germany. And so when they realized that the average mean rate of periodontitis progression are consistent across all observed populations of the world. And however, there are specific segments of population that can exhibit different levels of disease progression. So what are the key elements of when you want to define periodontitis? So the main features that evaluate the factors that when you want to define periodontitis or diagnose periodontitis is that we would be looking at severity, that is the degree of periodontal breakdown. We need to look at extent, that is the number and distribution of the teeth. We also need to look at complexity of the management, which is the probing depth, the bone loss type, the furcation, tooth mobility. We also should be looking at the rate of progression of the disease and the risk factors And what evidence, there are many risk factors you would know, but evidence has shown the two risk factors that have been associated with periodontal disease essentially is smoking and diabetes. So a case definition of a periodontitis case would be when you have an incidental clinical attachment loss is detectable. And this is only when you are able to assess the CEJ. And the threshold is that it should be detectable at more than 2 non-adjacent teeth. Or a buccal or an oral cal of clinical attachment loss of more than 3 millimeters with the pocketing of greater than 3 millimeter is detectable again at more than 2 teeth. And however, this observed clinical attachment loss should not be or cannot be ascribed to non-periodontal causes such as gingival recession of traumatic origin or a dental caries extending to the cervical area of the tooth. The presence of clinical attachment loss on the distal aspect of the second molar associated with malposition or extraction of a third molar, an endodontic lesion draining through the marginal periodontium, or the occurrence of a vertical root fracture. So this is just a case definition of periodontitis. Okay? So we have to go further and diagnose the case and define the case further. Is we would be going through different steps for characterizing a periodontitis case. And these 4-step practical approach was given by Conman in 2018. And so the step 1 is you have a new patient, okay? And this step actually enables the clinician to discriminate between periodontal health, gingivitis, and so you're going to suspect the case that it is a periodontitis case by doing the basic periodontal examination. Now, when the step 2 is now you suspect the patient of having periodontitis because you saw there's a clinical attachment loss or you saw some radiographic bone loss. And so you want to confirm it now and you want to differentiate between the different forms of periodontitis is that you're looking also at the patient history and you want to make sure that it is not because of a systemic cause and or it is not a necrotizing case. Now that you have confirmed that it is a case of periodontitis, you move to the third step, that is you look at the severity, that is amount of bone destruction that has occurred, and you look at the complexity of management of periodontitis case. And staging actually involves 4 stages from 1 to 4. And once you have done the staging of the case, you're going to the next step, which is grading. And in this step, you're actually looking at the risk profile of the case, and grading involves 3 grades, A to C. So let's see what we used to be doing in 1999. And in 1999, we were only looking at the extent. Yes, we were looking at the extent, that is, we were looking at the number of distribution of teeth that were affected. And yes, we were looking at severity, and that is the degree of destruction and breakdown. And that is why we used to, in case of chronic periodontitis, we used to classify it as mild, moderate, and severe. But there were so many things that were missing in the puzzle that we were not looking at. And so in 2017 classification, we were also looking at rate of progression. So we've now kind of completed the puzzle here. And we're looking at the complexity of management. And we're also looking at the risk profile of the patient. So actually what we're doing is we are now individualizing the diagnosis of the patient. Okay? And so we're moving more towards a precision-based medicine approach. So the way I would like to look at it is that this framework of new classification is actually inspired by oncology. And in oncology, if we know that cancer is, we know that there is the staging of cancer, and the staging of cancer actually represents the clinical representation is how much has it spread and what is the size of the cancer. And grading essentially looks at the risk and the rate of progression and the management of the disease. So this concept was actually taken up from oncology. And I would say, like, even a layman, when a layman is told if the patient is about certain stage of cancer, even a layman understands and can relate, okay, how bad it is. So now it's actually with staging and grading, it's we're actually making it simple, and we're trying to individualize the case and moving towards a precision-based medicine approach. So what's the framework of new classification looks like? It individualizes the diagnosis and the case definition of periodontitis patient, and it aligns its principles to the personalized medicines by using the risk assessment, multifactorial etiology of the disease, and the level of complexity of management. So let's look at each step one by one. The step one, as I said, is identify a patient with periodontitis. And so you need a detailed medical and dental history of the patient here, and you need to see if there are radiographs are available. So how do you go about it? Let's see. So step one, you have a new patient and you see if the radiographs are available. If the radiographs are available and it's of a good diagnostic quality and you're able to detect marginal bone loss, then it's a case of, then you can suspect it to be a periodontitis case and you move to the next step. However, if the radiographs are not available, or even if they are, you're not able to assess the marginal bone loss, you look at the interdental clinical attachment loss. And again, if it is present, you can suspect it to be a case of periodontitis. If not, you are looking at the buccal or the oral recession and the pocket depth, which has to be greater than 3 millimeter. And if that is so, again, you would suspect it of a case of periodontitis. And if not, then you just measure the bleeding and probing. And if it is less than 10%, then remember the 10% rule, it is periodontal health. And if it is more than 10%, it is gingivitis case. Step two is, now that you suspect the patient of having periodontitis, you want to confirm it through a comprehensive periodontal examination and charting. And at the same time, you want to look at or assess the current periodontal status of the patient. So how do you go about it? Is again, so you have a suspected case of periodontitis where you saw that there is some attachment loss, but you want to confirm that this attachment loss is not because of the local factors, that is endoperial lesion or vertical fractures, or because of caries or restoration, or because of impacted wisdom tooth. And if so, then you go back to the step one and measure the bleeding profile of the patient. And if it is not because of the local factors, and as we discussed in case definition of periodontitis, the threshold that clinical attachment loss has to be present on more than one non-adjacent tooth. And if that's not the case, then you assess the gingival inflammation, monitor it, and measure the bleeding and probing. So now we know now it's not the case of periodontitis. Okay? But if the clinical attachment loss is present on more than one non-adjacent tooth, it's a suspected case of periodontitis. And you are going to now do the complete periodontal charting for the patient. You will measure the pocket depth, which has to be more than 4 millimeter. And if it is less, then you measure the bleeding profile. And if the patient has no bleeding on the bleeding on probing is less than 10%, it is periodontal stability. If it is more, it's a gingival inflammation in a periodontitis patient. And in case the pocket depths are more than 4 millimeter, now it's a periodontitis case whose complete periodontal bone appraisal you need to do. That means you need to now, because you have to do the staging and the grading of the patient. Now, step three is you're going to look at the amount of the severity of the periodontal disease, and you're going to look at the complexity of the management of the case. And that's what staging is all about. And the information that you need for this is the periodontal charting. Likewise, you need to assess the clinical attachment loss. You also need to have a full mouth radiograph to assess the bone loss. And you need to know the history of tooth loss that has occurred due to periodontitis. The note, remember here, is that the marginal bone loss is that you are looking is the percentage of bone loss in relation to the root length. And what you assess is you you're not supposed to look at the entire each and every tooth. You actually choose the worst value of any site in the mouth. So you're looking at the worst tooth in the mouth. So what I would actually do when I'm in the stage 3 of staging, I would first actually define the extent of the disease, as we used to do previously also in the 1999 classification. For example, this case, it's a generalized case because more than 30% of the teeth are involved. And this case, as we can see, is only molar area in the lower anteriors and probably some in the upper. So it's a case of localized, which has less than 30% of the teeth which are involved. So staging, how we go about is that staging involves first, you're going to look at the extent. So you'll use the 30% rule here of localized and generalized. And then you look at the severity of the breakdown, which includes the clinical attachment loss, bone loss, and periodontal tooth loss. And further, you look at the complexity of the management of the case. And so you, based on that, you would actually stage the patient into 1, 2, 3, and 4. To make it simple, it is almost similar to what it was in 1999, where we could stage, where we had some incipient lesion, moderate, and stage 3 was severe there, and which was based on the attachment loss of 1 to 2 millimeter is incipient. Moderate is when it is 3 to 4 millimeter of attachment loss, and stage 3 is severe, where there's a potential for additional tooth loss and the attachment loss is more than 5 millimeter. However, here now a fourth component has been added, and stage 4, when there's an extensive tooth loss and the attachment loss is more than 5 millimeters, and a lot of complexity factors that that also that we're going to look in order to classify it into a stage 4. Another way to classify into different stages is looking at the marginal bone loss, on that is the percentage of bone loss in relation to the root length. So in an incipient or stage 1 case, we'll have a bone loss only till the coronal third, which is less than 15%. So basically, it actually would be difficult to assess on just based on radiograph. And so you might have to actually, for such cases, go check actually the clinical attachment loss. A moderate case would have bone loss in the coronal third, which would be around 15 to 30%. In stage 3, the bone loss is in the middle third, and in stage 4, it is in the middle third or beyond. So this is the whole periodontal charting, and it's given in, if you go to the site perio.org, you can always download it and use it when you are actually assessing your patient. So, and you can circle whatever is there in your patient. So what you look at in stage is that you're not just looking at the clinical attachment loss and radiographic bone loss or tooth loss. You're also looking at the complexity factors, and which might just change your stage. And looking at the complexity factors is actually very important when you, in order to differentiate stage 1 and 2 from stage 3 and 4. And also you're looking at the extent and the distribution. So how we go about is that, so once you know it's a periodontitis case, and you do the bone appraisal and you look at the severity and the complexity. So if the level of bone loss versus clinical attachment loss, if it is between the middle third and the clinical attachment loss is 5 millimeters or more, it is a stage 3 or stage 4 case. Whereas if the clinical attachment loss, also when there is a furcation involvement, it becomes stage 3 or stage 4. And if the pocket depths are greater than 5 millimeters, again, it goes to a stage 3 or stage 4. And if the pocket depths are less than 3 to 5 millimeters and there is no tooth loss, it's a stage 1 or 2. Whenever there is a tooth loss present, it becomes a stage 3 and 4. Now you need to further differentiate and see in whether it is stage 3 or stage 4. Is now you would actually look at other complexity factors. And if, for example, if you have a periodontal tooth loss, which is more than 4 teeth, will be more than 5 teeth, actually, it becomes a stage 4. And in case there is a bite collapse or there's a severe ridge defect, automatically goes to stage 4. And how you differentiate between stage 1 and 2, as I said before, that you would actually look at the clinical attachment loss, which is 1 to 2 millimeter in stage 1 and 3 to 4 millimeter in stage 2. So what you're doing is, when you're looking at the complexity factors, you're fine-tuning your staging. And also, why is it important is that a patient which has a stage 4 periodontitis case would actually, it's important to know that, because such patient would require a multifactorial, a multidisciplinary approach to treatment, and we need to understand that. And also, it may not be possible, every time that the patient may actually give you the right answers regarding to the loss in the periodontal history, regarding to why did he or she lost the tooth. And so there may be redundancy in it. And so you can always look at the other factors. And what I need to tell you here is that it's not necessary that you should be able to fill everything that is there in the grid. The next step is grading. And grading actually estimates the future risk of periodontitis progression. So till now, in 1999, we were not looking at this part. We were only talking about the past destruction, and we were not estimating what is the future risk of periodontitis progression in the case. And also, what grading assess is the likely responsiveness to the therapeutic principles. So basically, grading adds another dimension and allows the rate of progression to be considered in our diagnostic process. A periodontitis grades can further be modified by the presence or absence of the risk factors, which predominantly are smoking and diabetes. So grading can be done in 2 ways: by use of a direct evidence. So if you have a previous 5 years record of a patient available, or if you don't have a previous 5 years record available of your patient, then you assess the bone loss at the worst tooth affected as a function of age. So in staging, we were not looking at age. We were not thinking about age. We were only looking at the worst tooth, the tooth which had the maximum bone loss or the maximum clinical attachment loss. But here we are also thinking about age of the patient, and we are actually now calculating the percentage of bone loss by age. So grading is actually a rate of progression. And so grade A is a slow rate of progression, grade B is moderate, and grade C is rapid rate of progression. How do you calculate? For example, this case is a patient who is 42 years old, and the total root length here is 16 millimeter, and the radiographic bone loss is about 8 millimeter. That is, it is extending almost to the middle third of the root. And so the percentage of bone loss is equal to radiographic bone loss divided by the total root length into 100, which here is 50%. And the rate of disease progression would be percentage of bone loss divided by age, which would be 50 divided by 42 is equal to 1.19, which is greater than 1, so it becomes a grade C. Now, a simpler way to look at it would be, in case you have a patient, if the percentage of bone loss is less than half the person's age, it is grade A. And if it is more than half the person's age, it is grade C, and everything in between would be grade B. So how you go about grading is that you assess, as I said, you assess the bone loss and the age, and you look at, and so based on that, the patient will be either in grade A, B, or C. And but you also have to look at the grade modifiers. Like, these are the risk assessment profile of the patient. So the risk assessment profile of the patient, or the grade modifiers, are 2. They are smoking and diabetes. So if a patient is not a smoker, there is no change in grade. But however, the patient is a smoker, but he's smoking less than 10% per day, then upgrade your grade to grade B. And if it is more than 10 cigarettes per day, then you are going to upgrade your grade to grade C. Similarly, for a diabetic patient, if the HB one AC level is 7.0 or more, you upgrade it to 7. And if it is less than 7, you upgrade it to grade B. So this is the lookup table of the grade. And again, this is there on the site. And I would actually recommend all of you to have a print of it in your clinics along with you when you're looking at your patient. So you can always circle it and with whatever is there your patient, and it will be easier for you to decide the grade of your case. So the points to consider here would be, you're going to use the worst affected tooth. You must always also use your clinical judgment in staging and grading the patient. And those staging and grading do not help to create a diagnosis, but they actually act as a guiding stars to define the diagnosis and the prognostic tool. So what are the clinical implications? Now, if a diagnosis of a periodontitis case previously is now reported based on stage and grade. For example, what previously we used to report as generalized moderate periodontitis would now be reported as a generalized stage 2 periodontitis grade A, B, or C. And if a patient is a diabetic and the level is 8, for example, then the diagnosis is stage 2 grade C. In absence of smoking or diabetes, the progression of the case is determined by grading. So how are we going to apply this classification of periodontitis to our clinical cases? So I'm going to take you to, and I'm going to discuss 2 clinical cases with you. And I want that you also, when I'm discussing this, that you people should start forming in your mind the diagnosis. So here is the patient, and the patient is 37-year-old female. The chief complaint of the patient is that she has bleeding from gums when brushing and when biting into hard foods. The history is that the patient gives a 12-month history of the symptoms, and over recently the bleeding has become more evident. Patient is in a good medical health. There is a family history of periodontitis, and the patient is not a smoker. So these are the intraoral examination pictures of the cases. And here's the radiograph, the panoramic radiographs, and this is the periodontal charting of the patient. Now, I'm looking at the periodontal charting. If I say, and there is a clinical attachment loss on more than 2 non-adjacent teeth, and also when you're just looking at the radiograph itself, actually you can see there is a bone loss on more than 2 non-adjacent teeth. Okay, so I can see the bone loss in the 1-6 region, in around the 1-7 also, and in the 3-6 region. So it is a case of periodontitis, and through my charting, we were able to confirm that it's a case of periodontitis, and there was no systemic diseases that was affecting. So now we go for the next step is that we want to stage the case. So staging is actually looking at the severity. So let's take up the case, the tooth which has the worst bone loss, and I think it's this one. It is 3-6, which has the maximum bone loss, and what you can see is that this bone loss is almost extending till the middle third of the tooth. So till now, we knew this is the case of periodontitis, and it is, staging would be based because it is on the middle third. Sorry. So it's a case of localized periodontitis, and the stage is stage 3 because it is almost between 15 to around 33% bone loss has occurred, more than that actually. And grading would be grade C, because if you're going to look at the amount of bone loss that has happened, and the patient is 37 years of age, and the bone loss is approximately 50%, as we could see here, it has reached the middle third. And so if we go by that number, patient comes under grade C. And so the diagnosis of localized periodontitis, stage 3, grade C. Now let's look at another case. This is a male patient who's 28-year-old. The patient is undergoing orthodontic treatment and was referred by his orthodontist. Systemically, medical status, the patient is healthy. The patient smokes 5 cigarettes per day. On examination, it was observed that the patient is a mouth breather, and there are large accumulation of bacterial plaque is detected, along with gingival inflammation. There's bleeding and there's food impaction. So this is the case. The radiograph, panoramic radiograph is not that clear. So probably we can have a look at the full mouth radiographs and the bite wing. So you can see there is some amount of bone loss, right? And so we suspect this to be a case of periodontitis, and we do a full mouth intraoral examination and charting. And full mouth intraoral examination and charting actually revealed this patient had attachment loss, had generalized attachment loss, and based on the case definition of periodontitis, we were able to confirm it as a case of periodontitis. So the next step is we want to establish the extent, and attachment loss actually had affected more than 30% of the teeth, and the pocket depths were greater than 4 millimeter in more than 30% of the teeth. So by that, we can say it's the case of generalized periodontitis. And now we want to go to the next step. That's want to stage the patient. So again, we are looking at the radiographs here, and also the amount of attachment loss, which is only between 1 to 2 millimeters. And if you're looking at even at the bone loss, it is just at the cervical third. So by going by that, it is stage 1 case. And now let's go to the next step, is that we want to grade the patient. So the bone loss is only around 8% in this patient, and the patient is 28 years of age. So that would result in 0.28, and this is a grade A case. So you can say it is a case of generalized periodontitis, stage 1, grade A. But now I also need to look at my risk factors, and remember this patient is a smoker. But however, he's smoking less than 10 cigarettes per day. So now I'm going to upgrade it, and the grade would therefore become grade B. So the patient is a generalized periodontitis case, stage 1 and grade B. So how does this grading and staging actually is what we are doing is we are individualizing our case, and by doing so we are actually moving towards precision-based medicine. And how does it help in treatment planning? So a stage 1 a grade A or B case would actually just require a standard periodontal therapy, and in a stage 2 grade A or grade B case would require a standard periodontal therapy. Along with that, we may require pharmacological agents and reassessments following the initial periodontal therapy, whether the patient is the response of the patient to a periodontal therapy. And a grade 3 or a grade 4, stage 3 or stage 4 and grade B or C case is the one which has which require a complex periodontal therapy. And especially when you're looking at stage 4, where there is a bite collapse, the patient has lost many teeth. And so such patient would actually require oral rehabilitation treatment plan, and a complex periodontal multidisciplinary approach would be required for this patient. So by doing staging and grading is actually we are able to have a picture in our mind the kind of treatment that the patient would require. So the next section is the periodontal manifestations of systemic diseases and conditions. I'm going to quickly take you through this section. And the workshop group actually were looking at were challenged with the following questions, and that is, is there a possibility of characterizing a systemic disease based on the effects of underlying mechanism on periodontium? And if so, could we identify the disease and conditions that affect the periodontium? And should diabetes and smoking be associated periodontitis be a distinct diagnosis? And yes, the answer to the first question is yes, there's a possibility of characterizing systemic disease based on the effect of underlying mechanism. And so they were able to characterize it on under genetic causes, inflammatory causes, and metabolic disorders. And they were able to identify the cases that could affect the periodontium, and they were grouped into systemic disorders, have a major impact on the loss of periodontal tissues by influencing the periodontal inflammation and other disorders that influences the pathogenesis of the disease. And the systemic disorders that have a major impact included genetic diseases like Papillon-Lefebvre syndrome, you have leukocyte deficiency disorders, and you had metabolic and endocrine disorders. Then we had inflammatory diseases like the inflammatory bowel diseases. And another category was systemic diseases or conditions that affect the periodontal supporting tissues. And this included disorders that can result in loss of periodontal tissues independently of the periodontitis. For example, the neoplasms or the other disorders that affect the periodontal tissues, example, Langerhans cell cytosis. The next question was, should diabetes-associated periodontitis be regarded as a distinct diagnosis? And the answer is that there was no characteristic phenotype feature unique to periodontitis in patients with diabetes mellitus. They did not find any evidence of that. But of course, diabetes-associated periodontitis is what they said is not a distinct disease, but it is important as a modifying factor for periodontitis. And so this should also be included as a clinical descriptor in the clinical diagnosis. And the way we are looking at it is like in a part of grading, that it influences the grading of a periodontitis case. Similar thing applies to smoking. And what they said is that dependence on nicotine is a medical disorder, and there was no unique periodontal phenotype related to smoking. However, smoking is an important modifying factor and should be included in diagnosis as a clinical descriptor. And the number of cigarettes that the patient is smoking actually influences our grading. We already have discussed that part. So the next part is mucogingival conditions. And the important thing here is that now in 2017 classification, importance was given on the periodontal phenotype. And what is a periodontal phenotype? A periodontal phenotype includes the gingival genotype, which is gingival thickness and the width of the tissue. And it also includes the bone morphotype, that is the thickness of the buccal bone plate. And how do we assess if the patient has a thin phenotype or a thick? The simple tool is to use your probe, and if you're and insert it into the sulcus, and if you are able to see a probe, then it's a case of thin phenotype, and a thin phenotype always has an increased risk of recession. So the mucogingival conditions are classified taking into account clinical parameters like a gingival phenotype. We also look at the interproximal attachment loss and the characteristics of the exposed root surfaces. So the classification for gingival recession to be followed is the Cairo classification, which was given in 2011. And please have a look at the pictures. Recession type 1 or RT1 is the one in which there is gingival recession with no loss of interproximal attachments. The interproximal CJ is not detectable on mesial or the distal aspects of the teeth. Whereas RT2, have a look at this picture here, is where you see the difference in the probing depth. So when you have a gingival recession, which is associated with, there is an interproximal attachment loss, but it is less than or equal to the buccal attachment loss. And RT3 is, as you can see here, the interproximal attachment loss values are more than the amount of attachment loss on the buccal surface is the RT3. So basically, the classification of mucogingival conditions is would have to be organized in a structured way, and for that it utilizes factors like the gingival side. We're looking at the recession depth, thickness, and width, and on the tooth side we are looking at if the CJ is present or not. And if the CJ is present, it is A. If it is not, it is B. And whether the step that is present, the step because of the NCCL lesions or anything, if there's a cervical step that is present, so presence of step or not is reported as plus or minus. And on the other side here, we are looking at the gingival recession and presence of recession or no recession. And so basically what we are doing is, again, like in a periodontitis case, we are trying to individualize the diagnosis of the patient. That would help us in the treatment planning. The next part is the occlusal trauma and traumatic occlusal forces. So traumatic occlusal forces, the word now replaces the term excessive occlusal force of the previous 1999 classification. And what exactly is a traumatic occlusal force? Traumatic occlusal force is an occlusal force that results in injury to the teeth, such as an excessive wear or a fracture, and or to the injury to the periodontal attachment apparatus. Now, the thing you need to understand here is occlusal trauma is a histological term. And this is the histological term to describe an injury of the periodontal attachment apparatus. Traumatic occlusal forces can be classified as primary, where the periodontium is intact, and the injury, and secondary occlusal forces is where it's a reduced periodontium, and in that cases, even a normal force can become traumatic, and it can also be classified into an orthodontic forces. There is no evidence from human studies that traumatic occlusal forces accelerate the progression of periodontitis, or they can cause a non-carious cervical lesions or even gingival recession. The next thing we're going to look at is the prosthesis related and tooth related factors. And in this, the term biologic width, which we used to use before, is now replaced by supracrestal tissues. And this consists of junctional epithelium and supracrestal connective tissue fibers. And when they looked at the evidence, they reported that the workshop group reported that an infringement of restorative margins within the supracrestal connective tissue is associated with the loss of periodontal supporting tissues. So coming almost to the end now is peri-implant diseases and conditions. I'm going to quickly go through it because this had already been explained very well by Dr. Anil. So how do you evaluate peri-implant health? The first thing that you must do is by evaluating is by doing a visual examination and palpate the site and look for signs of inflammation. If there's absence of signs of inflammation such as swelling, redness, and bleeding and probing, it's important here as in case of health or differentiating between health and gingivitis also. Similarly, it is important here to use a probe because that's the only objective way to assess. So probing is important part of evaluating a peri-implant tissue, and to assess the bleeding on probing, we have to monitor the probing depth changes also at the same time. It is not possible to define the range of probing depths that are compatible with health because of the difference, because the placement of an implant may be deeper in some cases, and also peri-implant health can exist around implant with a reduced bone support. So coming to the case definition of peri-implant health in day-to-day practice would be an absence of clinical signs of inflammation, absence of bleeding and or suppuration on gentle probing, no increase in probing depth compared to a previous examination, and no bone loss. So what is peri-implant mucositis? Peri-implant mucositis is the one where there is slight bleeding, there's bleeding on gentle probing, there may be erythema and swelling or suppuration may be present, but there is an absence of bone loss beyond the crestal bone level changes, which have resulted from initial bone remodeling. So case definition of peri-implant mucositis in a day-to-day clinical practice would be bleeding and or suppuration on gentle probing, and there is no bone loss. Bone loss is only what has occurred during the first year of remodeling. Beyond that, there is no bone loss. Okay? And peri-implantitis, the diagnosis of peri-implantitis requires presence of bleeding or probing, increase in the pocket depth as compared to the previous examination, or a presence of bone loss beyond the crestal bone level changes, that is the remodeling that occurs from the initial bone during the initial phase. So the case definition of peri-implantitis in a day-to-day clinical practice would be bleeding or suppuration on gentle probing, an increase in pocket depth compared to the previous examination, and a presence of bone loss. So in the absence of previous examination data, a diagnosis, how would you make a diagnosis of peri-implantitis, can be based on a combination, that is when you have a bleeding and or suppuration on gentle probing, or you have have a probing depth of greater than 6 millimeter, or the bone levels are more than 3 millimeter apical to the most coronal portion of the intraosseous part of the implant. So this is a checklist then that I had prepared, and this is easier for me now. I can keep ticking it, and based on the checklist, I can actually decide whether the patient is in peri-implant health, mucositis, and peri-implantitis. So to summarize, is that contemporary system, the 2017 classification is actually a contemporary system for classifying the periodontal disease. And this system of classification actually aligns with the concept of precision-based medicine. Again and again, I'm saying that it is a personalized medicine. It is the way now we treat in medicine. It is the way now we treat in dentistry. It is more of personalized based treatment, because we now understand that every patient is different. And actually, this classification, by using the staging system and by using the grading system, is we are now able to personalize the diagnosis and formulate the treatment. And the way I also look at grading, I would say, is that is something like the way we used to get grades in school. Probably if I was a notorious child, my teacher would give me a grade C. And when, however, if my behavior improved, my grade could be upgraded. For example, let's take it from perio. If the patient has a risk and is a diabetic, for example, for example, the patient is a smoker, but the patient has been able to stop the smoking, the grade can be upgraded. But can you go back in stage? I would say no, you cannot go back from stage 3 to stage 2 or stage 1. And because the only exception here would be once you have done a guided GBR procedure and you've been able to achieve bone gain. Okay? Also, the diagnosis in 2017, last diagnosis is made in order to support the prognostication and treatment strategy. However, in the end, I would say your clinical judgment of the clinician is equally important. So thank you. These are the references, and thank you all for your patient listening. And you can reach me on Facebook and Instagram, and this is my email address. And if there are any questions and answers, I will be ready to take that. Thank you all. Neeraj sir, I've ended my presentation. So can we take some question and answers now?
Thank you very much, Dr. Minu, for your wonderful lecture. And it was like a very simple, in a very simple language, you have explained the intricacies and complications of the classification, which is always a very complicated and dicey topic for the postgraduate students. So if you permit, we'll take few questions.
Yes, sir.
So the first question students have asked is that how are we supposed to give diagnosis of gingivitis using new classification?
So as I said, you're going to use the 10% rule, and if it is if it's a case of, if it is bleeding is more than 10%, it's a case of gingivitis, and then you look for the extent that is localized and generalized. And the next thing that you can also add to your notes is the modifying factors, the local and the systemic modifying factors. That's the way you're going to classify the case.
Okay. Second, what if some factors of the tooth represent stage 1 and some represent stage 2?
So you're actually looking only at the worst tooth scenario. As I said, you cannot have two stage in one case. So you choose the tooth the worst, the tooth which has the maximum bone loss or which has the maximum attachment loss.
Why do orthodontic forces included in traumatic occlusal forces?
It was there before also. When we read about the chapter, we also discussed. So, but now with the evidence, it has been included that orthodontic, because it is the way the orthodontic treatment is done, and sometimes orthodontic forces can cause traumatic, can be traumatic.
Okay. The last question, in your case number 2, what will be the diagnosis if patient gives a history of more than 10 cigarettes per day? The diagnosis will remain same as you said, or will it change?
No, the grade would then change, right? Because in the second case, it was grade B. But if the patient is now smoking more than 10 cigarettes per day, the only thing that would change is the grade.
Okay. Thank you very much, Dr. Minu, for your wonderful lecture. And now what we'll do is that since this is the last lecture of the series, we will just have some concluding remarks from our Honorable President Madam and Secretary Sir. They have joined us here today.
Good afternoon, everyone. And very nice lecture, Minu. Although I couldn't hear the whole of it, I was on duty. I just came and joined, and I could hear in pieces and this. And thank you so much,
thank you, ma'am.
And whoever has joined from the speaker point of view, I am very thankful to them. It's only because of them that this could be a successful venture. And I am very thankful to Dr. Neeraj for conducting it so seamlessly, so nicely. And I didn't know you had so many hidden talents. You are doing it. You did an amazing job. And I was talking to many people. They said that they had to hire a special person, and then that would mean, and we did it in very minimal amount, I think. It was not much.
Yes,
it was not much. So thank you so much. Thank you, all of you. And I would ask Dr. Grover to say something about this whole webinar series.
Thank you, Nymphia ma'am. Good afternoon to you. Good afternoon to Neeraj sir and Dr. Minu also. Wonderful lecture, Dr. Minu. And it was really very nice to hear about the new classification system. Of course, so beautifully moderated by Dr. Neeraj. Here I must say that Dr. was Dr. To have this ongoing series of webinars, and how 2 months have flown away. It is really amazing. And 2 months of, as Madam rightly pointed out, of seamless, streaming and coordinating by Dr. Neeraj. So thank you, Dr. Neeraj. Thank you, Madam also. Thank you all the office bearers and EC members, and thank you all the speakers, and of course our wonderful students. I hope if you have liked it, we will envisage something like this again for your benefit, and happy learning. Thank you so much, all of you.
Very wonderful remarks we have received from the students. We have a group of, we had made a group of Samiksha. So on that, I am really touched by what they are saying. They are saying
I'm sure, ma'am. I'm sure. Actually, we have also, really liked all the speakers, and they were all very wonderful.
And Dr. Neeraj was doing double job as a speaker also and as a coordinator also.
Credit all our galaxy of speakers, and I wish to really thank them for it. And thank you very much, sir. And so today we come to end of our 2 months of marathon lecture series by Indian Society of Odontology with almost 18 speakers we had, and which is and the total views of our presentations videos have gone across more than 70,000. So
my God.
Wow, that's great, sir.
Amazing.
Three cheers. Three cheers.
Yes, 3 cheers.
we have got people views from all over the world. So it has been a really success. So we'll just have a short certificate, virtual distribution of the certificates to all the speakers. And as we speak here, the certificates are being emailed to all the speakers, and they will receive the certificate shortly. So first, Dr. Abhay Kolte, sir, for his lecture on clinical diagnosis. Dr. Anil Melat on his wonderful lecture on implant complication and its management. Dr. Ashish Jain, sir, for his lecture on journey of dental plaque to arterial plaque. Dr. Ashish Kumar for his deliberations on role of occlusion in periodontal disease. Dr. Baljit Singh on his lecture for host modulation therapy. Dr. Biju Thomas for his lecture on medically compromised patients, periodontal management. Dr. Ganesh on elaborating on landmark studies in periodontology. Dr. Gopal Krishnan on supportive periodontal therapy. Dr. H.S. Grover, sir, on elaborating on the controversies in periodontology. Manish Khatri, sir, on elaborating and deliberating on endoperiod lesions. Dr. Minu today speaking on the classifications of periodontal diseases. Myself, I had given a short lecture on biofilms and periodontal.
Oh, it was very nice. Very good.
Nymphia madam has very wonderfully explained immunity and inflammation, one of the very complicated topic which everyone is scared to even touch. And Dr. Rameshwari, periodontal regeneration. Dr. Roshni Thakur, who was our opening batsman for this lecture series.
Yeah, and I had given her just 1 week, imagine.
Yes,
Just 1 week.
Yes, sir. And Dr. Shalu for demystifying lasers. Dr. Subhash Raj very wonderfully explained about the periostitics. And Dr. Vishaka Grover on tissue engineering, which was, this topic was on demand by the students themselves. So I wish to thank Indian Society of Periodontology and all galaxy of our speakers for making this program a grand success. Thank you. Thank you very
You have
much.
made it like a professional
Thank you, Dr.
one.
Neeraj. Yes.
It's so
And
much. Even this slide is so beautiful. Nice.
I want to say something, ma'am. I want to thank you and for giving me the opportunity. I want to thank Dr. Grover and Neeraj sir for actually conducting the entire event so well. Thank you.
Very nice.
Thank you, all of you.
Hope to meet all of you soon. That Corona,
Surely.
and we'll meet again someday.
We'll meet
Soon.
again, ma'am, in better times. Thank you.
Yes. That's what we wish.
Stay safe and stay healthy, everyone. Thank you.
Thank you so much.
Thank you,
Thank you,
Dr.
thank you.
Neeraj.